Mm. So in the previous lesson, we have started discussing about diabetes insipidus, the posterior pituitary gland disorder. So in short, DI is like insufficient production of antidiuretic hormone. So this ultimately causes dilation of urine. We have mentioned about the large volume will be actually passed like above 3 liter per day. And we have mentioned about the osmolarity of the urine will be very low. And even we have mentioned about the hypothalamic and the nephrogenic DI, the difference between the two. This one is deficiency and the other one is resistance. And we have mentioned even the etiologies of pituitary DI as well as nephrogenic DI, and we have mentioned even the clinical parameters of this condition, mostly polyuria and dehydration, and increased fluid intake are most common clinical presentation. And we have also mentioned about the diagnostic tests. Usually, we are going to look at the ADH level, osmolarity, both in the serum and the urine, and also even we have to use a desmopressin suppression test. Okay, then those are the come of the diagnostic modalities we have seen in the last time, and especially the desmopressin suppression test is very important to differentiate between central DI and nephrogenic DI. Okay, then today we are going to focus on about the management of central.
Sir,
yes, question.
a minute. During the last class, you asked a question about this test to differentiate between the central and nephrogenic.
Okay.
And I just need clarification again. I think I got confused somewhere.
Oh, you okay?
Could you repeat for just a minute?
You want to know about how we are going to differentiate between this test? Huh?
Yes.
What was your opinion in the first place? Like, what is your understanding?
Okay, so I know in the central one, you're not producing ADH, and in the nephrogenic one, you're not responding to ADH levels. So my thinking is, if you have central diabetes insipidus, then when you're given ADH during the test, then you're going to respond, you're going to have concentration of urine. Is that correct?
Yeah, yes.
While in the other one, you're not.
You don't see any effect. That means, let me say, this is central DI and this is nephrogenic DI. So now, remember, you know the difference between the two. Now, this one is deficiency, the other one is actual resistance. So when you give desmopressin, initially the osmolarity on both conditions are what? Low. At the baseline, like before we give desmopressin, the osmolarity of the urine is actually low. So low at the first place, low. So maybe we can say this is low and this is low. Then the moment you give desmopressin acetate injection, like after depriving water for 8 hours, now if the problem is central, the osmolarity of the urine will be increased, but this one we don't see any change, still the same. So that is how we differentiate. That means in case of central DI, there is a response, increase in osmolarity means like the problem is deficiency, is not resistant. But in this case, despite you give desmopressin, you don't see any change on the osmolarity. So it is the same as, mostly the same figure as compared to the baseline. So no change from the baseline and after deprivation or after giving the administration, but this one, there is an increase. So that is how we differentiate. So if increase means it is central, if it is still the same means it is nephrogenic DI. This is how we are going to differentiate.
Okay, sir. Thank you.
Okay. Then treatment-wise, the management of let's see about the management between central diabetes insipidus. So management-wise, they are totally different. In fact, even the presentations, despite some of the clinical presentation is the same, the pathogenesis is totally different because insufficiency and resistance. So in both cases, drinking water in sufficient quantity can work. It can actually even correct metabolic abnormalities. Yeah, because of they are actually losing a lot of water. So this is a best strategy at the non-pharmacological treatment modality. So let them drink as much as they can so that they can actually correct metabolic abnormalities. But in case if the oral intake is inadequate to correct the metabolic abnormalities, maybe we can consider intravenous administration of fluids. IV fluids like DW, dextrose in water, can be considered. Anyways, in short, fluid replacement is one option. But other strategies and the treatment of choice in case of central DI is desmopressin administration. So we do have synthetic vasopressin, and we do have also desmopressin in ways. Depending on the availability, we can use. So those synthetic administrations of vasopressins are the treatment of choice because the problem is deficiency. Like the gland is not producing sufficient level of ADH, so we have to give them the replacement therapy. Then, of course, carbamazepine can also be used. Maybe let me ask you a question. Which class of drug carbamazepine belongs to?
Benzodiazepines.
Carbamazepine. This is benzodiazepine.
Benzodiazepine.
Huh? It is under that class, Tiffany. Are you sure?
I need to think about it. I'm not sure.
Okay. Then anyone? Any other? Anna?
Don't have an idea.
Anticonvulsant, yes. It is actually anticonvulsant, but it is also a mood stabilizer commonly used in management of bipolar disorder. It can actually like stabilize the mood of an individual. So the rationale behind the use of carbamazepine, by the way, it is a sodium channel blocker. It just blocks. It has multiple mechanisms of action, but mainly it works on blocking the sodium channel. That is why it actually prevents abnormal firing of neuron when a patient is having seizure. But when you look at, and also even stabilizing the mood, so by causing hyperpolarization, it can actually even causes excitation of the neuron, so the patient can be calm and the mood will be stabilized. But the rationale behind the use of this drug in the management of central DI is because of its ability to stimulate the release of antidiuretic hormone. So it has a potential to stimulate the release of antidiuretic hormone. That is the main reason we're going to use it, carbamazepine. Despite the exact mechanism is not really known, how it causes release of antidiuretic hormone, it has a potential to increase release. So it is really used and employed when other parameters are unsatisfactory. So if we don't see sufficient response, even carbamazepine can be another option in case of central ADI. That is why, by the way, when a patient is taking carbamazepine, in case of maybe convulsion or in case of mood disorder, you are supposed to keep on checking the serum level of sodium because of its ability to increase the production of antidiuretic hormone excessively, it can cause dilutional hyponatremia. So this hyponatremia, the CNS effect is very determinant. It is very detrimental. It can cause tissue damage, confusion, and even loss of consciousness and ultimately even coma. So because of that, monitoring is like part of the recommendation for this drug. Desmopressin, we do have different route of administration, IV, subcutaneous, intranasal, the form of inhalation, or even orally. So this is a dosing schedule. If it is by injection, 1 to 2 microgram. If it is by nasal spray, this is a dose. If it is given orally, this is the dose you are going to give desmopressin. And onset of action is very rapid most of the time. If we give by injection within 15 minutes, you will see like those electrolyte imbalances will be rectified. But for oral, it was a bit delayed. It will be a bit delayed, like an hour after it will actually start. It is antidiuretic effect. So in short, in case of central diabetes insipidus, this class of drug or desmopressin administration is like the front line in the management apart from apart from fluid replacement. Otherwise, there is nothing much about the management of this condition. Then, when you look at about the management of nephrogenic DI, remember nephrogenic DI means is resistance. So, do you think desmopressin will be like a good option to treat this condition? Can we use desmopressin in the management of nephrogenic DI?
No.
No, why?
Because the body is resistant to the drug.
Okay, fine. So since the body is resistant, like desmopressin is not a treatment of choice. That is why before you actually diagnose the diabetic insipidus, you have to rule out which type. Is it resistance or insufficient production? So the lab parameters are very important to rule out whether it is nephrogenic or other one, because the treatment usually varies. So here, mostly we use diuretics. What was approved in the management of this condition is amiloride, the potassium-sparing diuretics, and hydrochlorothiazide. You can say 25 milligram once or twice daily can be considered. At least this one is widely available. Of course, we can use also endomethacin. So it seems like when you give actually diuretics, why we give diuretics if the patient is actually having polyuria. So the next slide will actually give you the answer why we give diuretics in the management of because when you look at like the information critically, the patient is losing a lot of water. So when you give diuretics, we are actually even exposing to be hypovolemic shock. But the rationale behind to give in this condition is when you give thiazide and amiloride, it can lessen urine volume as a result of volume contraction. So the principle behind or the exact mechanism is not really known, but they are saying it is most likely due to hypovolemia-induced increased proximal sodium and water reabsorption. The moment you give diuretics, what will happen? The hypovolemia can actually activate the proximal renal tubule to reabsorb water and sodium. So in such a way, it can actually cause what? It can actually cause or treat as nephrogenic DI. So that is the principal mechanism why we are giving diuretics in this condition, and it is approved. Then about the role of NSAIDs, remember non-steroidal anti-inflammatory drugs inhibit prostaglandin synthesis. So the moment you are blocking synthesis of prostaglandin, what will happen? It actually reduces delivery of solutes to the distal renal tubule. So ultimately, what will happen? It can actually reduce volume and increase urine osmolarity. So by inhibiting delivery to the distal renal tubule, it can actually cause what? Reduce urine volume and increase urine osmolarity. So that is the rationale why we're using NSAIDs in the management of this condition. Otherwise, there is nothing much about the management of nephrogenic DI, nephrogenic diabetes insipidus. So this is all about the management of those conditions, and please note the difference between the two, and apart from that, diagnostic modalities. So maybe before we go to like the short video, can we like actually discuss those few questions? So how is DI defined and characterized? It's just very straightforward question. So can we just interact? Alan, let me start from the word A. Alan, so how do you define DI? Alan is not in? Okay, fine. Yes, please speak up.
I mean, how do we define diabetes insipidus?
Yes, just briefly.
It is characterized by production of large amounts of urine, large amounts of dilute urine, and in the like in 24 hours.
Okay, good, fine. The other person, maybe who is Anita, I don't know whether she's in. So what are the presentations of DI, Anita?
I think it's when you produce large volumes of dilute urine.
Sorry?
When you produce large amounts of dilute urine.
Yes, okay, polyuria. Yes, that is one presentation, but of course, polyuria is not the only feature. Dehydration, even polydipsia can happen. Okay, then other person can tell us, okay, Anna? Anna, you'll tell us about what lab tests can be performed to confirm the diagnosis.
You can check the serum, electrolyte, and glucose levels, or you can check the urine-specific gravity, the osmolarity of the urine, also the ADH levels in the serum. Yeah.
Okay, fine. So those are the tests we can consider. Then how is nephrogenic DI characterized? Any other person? The next person will be who? Makina. Makina is a class rep, I think. Makina?
Nephrogenic diabetes is nephrogenic diabetes, it has chronic renal insufficiency, there is glycosuria, hypokalemia, hypercalcemia, and lithium toxicity.
Those are the causes, Okay, fine. I don't have any objective. So those are some of the causes of nephrogenic DI. Then what about the parameter, the lab parameters? How does the lab parameter look like? McKenna, can you try, or we just proceed?
The lab parameters for central...
Nephrogenic DI, how does it look like?
I don't remember very well.
Okay, fine. Any other person? Okay, then the next person will be Brian.
Yes.
Brian, can you try, how does the lab parameter look like when they're having nephrogenic DI?
For nephrogenic DI, I think well, lab parameters, maybe I just know like the actual condition, something to do with decreased ability to concentrate urine because of the lack of suppressing, what was it, ADH, resistance of ADH action in the kidney or something like that.
Okay.
Maybe the osmolality, if that's what you call it, is I think it's less than 200. I'm not really sure, sir.
Okay, fine. So in the next few minutes, kindly actually watch this video for the summary of this condition. I think the question, it seems like simple, but maybe you have not read. So just I'm going to share computer sound. Let me share this computer sound. Okay. Then you can actually listen properly, please. I beg you to listen so that you don't even, if you're actually actively attending, for sure, there is no like much reading. There is no even point of much reading if you're actively involving. Yeah? So please listen. Can you hear?
Hi, this is Tom from zerotofinals.com. In this video, I'm going to be going through diabetes insipidus. You can find written notes on this topic at zerotofinals.com/diabetes insipidus or in the endocrinology section of the Zero to Finals medicine book. Let's jump straight in. Diabetes insipidus is caused by either a lack of antidiuretic hormone, or ADH, or a lack of response to antidiuretic hormone. Remember that antidiuretic hormone acts on the collecting ducts in the kidneys and allows them to reabsorb water from the urine. So having diabetes insipidus prevents the kidneys from being able to concentrate the urine, and this leads to polyuria, or excessive amounts of urine, and polydipsia, or excessive thirst, because the blood is so concentrated. It can either be classified as nephrogenic or cranial diabetes insipidus, depending on whether the problem is in the kidneys or in the brain. And a key differential diagnosis of diabetes insipidus is primary polydipsia. And this is where the patient has a normally functioning ADH system, but they're drinking excessive quantities of water, and this is leading to excessive urine production. They don't have diabetes insipidus, but they present with polyuria and often polydipsia. Firstly, let's talk about nephrogenic diabetes insipidus, and this is where the collecting ducts of the kidneys don't respond to the ADH that's in the bloodstream. And this can be caused by a number of different factors. One of the key causes is drugs, particularly a medication called lithium that's used in bipolar affective disorder. There's also a genetic abnormality that leads to nephrogenic diabetes insipidus, and this is mutations in the AVPR2 gene on the X chromosome. Intrinsic kidney disease, so really any chronic kidney disease that's affecting the internal functioning of the kidneys, can lead to nephrogenic diabetes insipidus. And electrolyte imbalances can also be a cause, particularly hypokalemia, or a low potassium, and hypercalcemia, or a high calcium. Next, let's talk about cranial diabetes insipidus. And this is where the hypothalamus gland does not produce ADH for the pituitary gland to secrete. And this can be idiopathic without any clear cause, or it can be caused by brain tumors, head injuries, brain malformations, infections such as meningitis, encephalitis, and TB, or brain surgery or radiotherapy. The presentation is all linked to the excessive loss of water in the urine. So patients have polyuria, or excessive water production, polydipsia, or excessive thirst, dehydration, postural hypertension, so their blood pressure drops as they stand up. And if you check their blood tests, they'll also have hyponatremia, or high sodium concentration in the blood. How do you investigate them? You can do your Usenease blood test to check the kidney function, and you might find a hypernatremia. You can also check the urine osmolality, and you'll find a low urine osmolality because there's a low concentration of solutes in the urine. They've all been diluted by water. And you'll find a high serum osmolality, as there's a high concentration of solutes in the blood. The next test is called a water deprivation test. The water deprivation test is also known as the desmopressin stimulation test, and this is the test of choice for diagnosing diabetes insipidus. So how do you do it? Well, firstly, the patient needs to avoid taking any fluids or food for 8 hours prior to the test, and this is referred to as fluid deprivation. Then the urine osmolality is measured, and synthetic ADH or desmopressin is given. 8 hours later, the urine osmolality is measured again. So how do you interpret the results? Well, in cranial diabetes insipidus, the patient lacks ADH, so the kidneys are still able to respond to ADH. So initially, after that first 8-hour period of water deprivation, the urine osmolality will still be low as it continues to be diluted by the excessive water secretion by the kidneys. Then, after the synthetic ADH has been administered, the kidneys will start to respond to that synthetic ADH by reabsorbing water and concentrating the urine. So the 8 hours after the ADH is given, the urine osmolality will be high, and that way you know that it's cranial diabetes insipidus and the kidneys are still functioning normally. In nephrogenic diabetes insipidus, the patient is unable to respond to the ADH. What's happening is they're diluting their urine with excessive water secretion by the kidneys, and they're unable to respond to ADH. Therefore, their urine osmolality will be low after the initial 8-hour water deprivation and will remain low after the synthetic ADH is given. In primary polydipsia, the 8-hour water deprivation will cause the urine osmolality to be high even before the synthetic ADH is given. If you have a high urine osmolality 8 hours after water deprivation, you know that they don't have diabetes insipidus, so there's no purpose for giving ADH and doing the full test. You can exclude at this point that they have any diabetes insipidus. So just to briefly summarize those results, in cranial diabetes insipidus, you'll have a low urine osmolality after deprivation and a high urine osmolality after the ADH is given. In nephrogenic diabetes insipidus, you have a low urine osmolality after deprivation, and it remains low after the ADH is given. And in primary polydipsia, you'll have a high urine osmolality after deprivation, and of course it will remain high after the ADH is given. So how do you treat diabetes insipidus? Well, if possible, it's worth correcting the underlying cause. Often mild cases can be managed conservatively without any treatment. Desmopressin, which is synthetic ADH, can be used as a treatment in cranial diabetes insipidus to replace the ADH that they're not already making. And in nephrogenic diabetes insipidus, it can also be used, but often very high doses are required and close monitoring is necessary in order to get an adequate response from the kidneys. So thanks for watching. I hope you found this video helpful.
Okay, so this is all about the summary, what I want to show about this diabetic insipidus. But remember, make sure the primary polydipsia is a psychiatric disorder whereby the patient is actually taking a lot of amount of water, and ultimately they are like losing a lot of water. That is why when you deprive water for 8 hours, if the concentration of the osmolarity of the urine is high, you actually ruled out. So this is mostly related to the psychiatric disorder, which is known as primary polydipsia. So this is all about what I want to show about diabetes insipidus, the posterior pituitary gland disorder. So the next few slides, I'm going to take you through about what will happen when ADH is excessively produced in the body system. Like this is just hypersecretion. So remember, syndrome of inappropriate antidiuretic hormone known as SIADH, it involves the continued secretion or action. It could be secretion or action of ADH despite normal or increased plasma volume. So despite the plasma volume is actually normal, it is continuously acting and continuously producing. That means the negative feedback mechanism to regulate its production from the hypothalamus is actually not inhibited. So what will happen in this case? This ultimately results in impairment of water secretion and ultimately it causes consequent water retention. So as a result of water retention, what will happen? The patient can have hyponatremia. That means the concentration of sodium in the serum would be like less than 135 millimole per liter. And also there is a concomitant hypoosmolarity, like the osmolarity in the serum is usually below 280 milliosmol per kg. Paradoxically, the high or contrastingly, the urine osmolarity will be high in contrast to that of diabetes insipidus, because the ADH is working actually very high. So there is no like water which is excreted in the form of urine, so that the osmolarity of the urine will be very high. What really causes this inappropriate secretion of antidiuretic hormone from the anterior pituitary?
Excuse me, sir?
Yes.
Is there any relationship between this condition and diabetes insipidus?
Which one and which one?
The SIAD condition and diabetes insipidus.
No, there is no relationship between. This one is just excessive production, but the other one is actually the other one is deficiency or maybe resistance to the action.
Okay, thank you.
Yes, so that is why syndrome of inappropriate antidiuretic hormone stands for continuous secretion or action of ADH. That is how we are going to define. So inappropriate in the context of this syndrome is actually increase the action of antidiuretic hormone. So what really causes this continuous production of antidiuretic hormone and ultimately causes significant effect on water retention? So it can be due to ectopic production such as lung cancer. So remember, some malignancies such as lung cancer, also even neoplasm in the duodenum, pancreas, and ovary, they can ectopically produce ADH, so they are actually increasing the action of ADH from the collecting tubules of the kidney. Then apart from that, some CNS disorder, such as trauma, stroke, any meningitis, or any surgery in pituitary gland can actually cause damage of the hypothalamus or pituitary, which causes the failure of the feedback lobe that regulates antidiuretic hormone. So those CNS disorder, they can actually remember the regulation is hypothalamus pituitary. Then maybe we can say kidney. So this HPK axis is the one that regulates the production. So when there is a CNS problem, there is a probability when there is a damage maybe in the hypothalamus or the pituitary, that negative feedback regulation will be failed, so that there is a continuous production of the antidiuretic hormone, and ultimately it elicits like extra or supraphysiologic effect of antidiuretic hormone. So in summary, this is the diagrammatic representations of syndrome of antidiuretic hormone. So this is when there is ectopic production. So like the tumor independently, like without actual involvement of the pituitary gland, it actually produces the hormone independently, so that it actually increases action on this one. Then apart from that, when there is a CNS disorder, that dysregulation of the negative feedback mechanism increases release of antidiuretic hormone, then this ultimately increases action on the kidney, and ultimately the patient will retain a lot of water. So this is how it will happen. Then apart from that, some kind of pulmonary diseases such as asthma, pneumonia, TB, and COPD can also even increase the release of antidiuretic hormone. And apart from that, even drugs can enhance ADH release, such as oxytocin, carbamazepine. I think from here, what is very common and popular is carbamazepine and the anti-cancer drugs, the alkylating agent cyclophosphamide and vincristine, the vinca class of alkaloids, are notorious in causing this syndrome. They are actually continuously stimulating the release of antidiuretic hormone, and then ultimately it causes like delusional hyponatremia. So in short, some drugs can enhance the release, or some pathological condition can also increase the release, apart from the other causes what we mentioned in the previous slide. Okay, those are some of the etiologies of this condition. So having said this much, what are the clinical presentation when a patient is having this problem? Retention of water. So this retention causes dilution. That is the major problem. Then as a result of hyponatremia, the patient can confuse, become very lethargic and weak. Of course, even cerebral edema is also very, very, very common. Then, of course, as a result of accumulation, you will see like weight gain and hypertension, and even the output of the urine can be significantly reduced. So those are the most common clinical presentation. But since they are not specific for this condition, lab parameters are very, very important in the diagnosis. Then how does the lab parameter look like when a patient is having high level of ADH? The plasma level of ADH will be elevated. The specific gravity will be above like 1. The osmolarity of the sodium, osmolarity in the serum is low, and the serum sodium will be low. So serum parameter become low, but urine parameter can be elevated. Osmolarity and the specific gravity will be high. So this is how the lab parameter look like when we're checking.
Excuse me, sir.
Yes.
Why is it that in serum we're only considering sodium, the electrolyte affected, when there's more electrolytes, and considering the blood is dilute, all of them will be considered low because of dilution?
Yeah, good question. By the way, do you know sodium is like the most common cations in the extracellular fluid? Of course, there is a possibility of derangement, but when there is actually sodium is the predominant cations in the extracellular fluid, that means in the intravascular compartment. We do have other cations, but mostly they are intracellular. And apart from that, when there is a change in the sodium level, you will see significant consequence in the clinical manifestation, because sodium is the one that regulates even the body, like the plasma volume. So sodium is low means water will actually remove. So because of this, mostly we are concentrating on the sodium level because of its clinical implication, as well as because of like predominant concentration in the serum. That is why we are going to concentrate on sodium level. Otherwise, even the other parameter can be deranged, but this derangement is actually causing devastating complication. Good observation. Okay, so this is the parameter we are going to use. So the next slide will be the treatment. So what do you think about the treatment modalities to manage this condition? The problem is excessive action and excessive production. So how do we treat this condition? How do we treat this condition? Is there anyone who is willing to try? Christine?
Can you say
Okay, continue, Makina.
Can we say that the patient should restrict from drinking water?
Yeah, fluid restriction is like very important because they are actually retaining. If they take water, they are not actually removing, yeah, depending on the balance. So fluid restriction, one strategy. Any other modalities?
Because the problem is with oversecretion of ADH, can we give a receptor blocker?
Yes, we do have a drug which is specifically blocking the receptor. Okay, good observation. Fine. We do have a drug which actually blocks the action of antidiuretic hormone. Okay. Any other treatment modalities?
Can you give diuretics?
Sorry?
Can you give diuretics?
Yeah, diuretics can be used because they can actually reduce the blood volume. So that is another strategies. Okay, so let us see together about the possible approved treatment modalities. So restrict fluid intake, that is the first line treatment. Then treat underlying causes as much as you can. That means if there is a tumor, such as like lung cancer or maybe pancreatic cancer or any other neoplasm that increases ectoproduction, then treating underlying causes will be like the first modality of like curative treatment. Otherwise, if you give them maybe diuretics, you are actually like treating the symptomatic treatment. So as long as you're not treating the underlying cause, you might not achieve effective outcome. So then after that, if we are not able to correct the sodium level in the serum, like within 24 to 48 hours, that is when we are going to initiate any pharmacological treatment modalities. So the approved pharmacological modalities we're having currently, the anthracycline class of drugs, imeclocycline, they can actually block the action of ADH from the collecting tubule, and we do have also vasopressin receptor antagonists. They have a suffix vaptan, conivaptan, tolvaptan are available. So they are blocking the action of antidiuretic hormone from the collecting them. So in such a way, they can prevent the action. And of course, diuretics can be considered if the initial response is not adequate, maybe in severe symptom, and if we want to actually rapidly treat hyponatremia, hypertonic saline, such as 3% sodium chloride solution can also be administered. So those are the only treatment modalities, the only pharmacological treatment modalities we're having currently in case if the patient is having this condition. But remember, treating underlying cause, if it is due to drug, discontinuing the medication will also be part of the treatment modalities of this condition. So finally, how do we monitor the response? Monitor for signs of fluid and electrolyte imbalance. That is very, very important. Then look at any neurological deficit or effects because of the sodium changes. Then monitor in and out. So that means you monitor how much fluid the patient is taking. Then you actually monitor how much is the patient is actually like losing. So I don't know whether you came across mostly the physician for a patient, if they are going to strictly monitor the fluid input and output in case of heart failure, they just normally put a catheter to measure the urine output. Then they will look out. Then they will actually look at whether the treatment was effective in terms of actually causing diuresis when they are having significant edema. So that is how they are going to monitor. They just insert a catheter, then it has actually having, I don't know whether you came across, it has actually having a like, it is graduated. So you will see like a measurement, leveled measurement from the catheter so that it can actually measure like the amount of urine output. Then of course, they also even change or assess any weight changes to see whether the treatment was effective or not. So this is all about posterior or pituitary gland disorder in brief. I just normally highlighted like the most important condition we might encounter, despite the conditions are very rare. Any question before we proceed to the next session?
Excuse me, sir.
Yes.
I had a slight connection issue earlier, but I came to find out that we use diuretics for nephrogenic diabetes insipidus in the earlier part of the lecture, but
Yes.
I couldn't understand why.
Oh, remember why we are going to use the exact mechanism is not really known. But what they are saying, when you give diuretics, you're actually like losing a lot of water. So that diuretics can actually increase like sensitivity of the proximal renal tubule. So by increasing sensitivity, like because of central hypovolemia, by promoting sensitivity of the proximal renal tubule, you are activating retention of fluid or absorption of sodium and water in the proximal renal tubule. Remember, there was absorption in different parts of renal tubule. So that is why we are going to use in those conditions. That is the only known mechanism. Hypovolemia-induced increases proximal sodium and water reabsorption in such a way they can actually treat this sensitivity or resistance to the action of antidiuretic hormone. Prostaglandin, did you get about the role of NSAIDs? The NSAIDs usually by causing constriction as a result of inhibition of prostaglandin synthesis, they can reduce delivery of the solute. So you are actually reducing the urine volume and increase urine osmolality. So that is why we are going to use those class of medication in case of this management. And those are the only approved treatment modalities.
Okay, so thank you.
Okay, fine. So this is all. If you don't have any other question, I think we can proceed to adrenal gland disorder. Now we are going to discuss another. We are going down from the top, and now we are actually reaching to the kidney, like the top. We have already discussed glands around the neck. Yes. Now the next gland will be the adrenal gland. Then we will actually go down accordingly. Okay, now let me share my slide about this condition, adrenal gland disorder. Okay, so what do you know about adrenal gland? What do you know about adrenal gland? I hope you have covered in physiology for sure. Have you covered in physiology in the first place?
Yes.
Yeah, for sure, no one can miss. Eh? Okay, good. So what do you know about adrenal gland, Tiffany?
They're found at the top of the kidney, and they're divided into two, the cortex and the medulla. And the cortex has 3 layers, glomerulosa, fascicularis, and reticulata, which produce aldosterone, cortisol, and the androgens, which is DHEA, and then we have the medulla that produces catecholamines.
Oh, okay. Thank you so much. Oh, by the way, Tiffany, yeah, Prof. Amai Normal told me to actually to pass her congratulations remark for winning the World Pharmacist Day prize winner.
Yeah.
I would like
Thank you.
to congratulate you.
Yeah, thanks.
Okay, what was the competition, by the way?
It was a competition divided into 3 slots where students from Kenya as well as India were being asked questions, general and a little specialized from different aspects of the pharmacy education to gauge their knowledge. So it had 3 stages. There's a preliminary competition, semifinals, and finals. I wasn't the only one, but I was the only one who won, but some of us also participated.
I think in Kenya, I just only saw your name.
They didn't pass the finals and win, but they participated. Some of the classmates also did.
Oh, so we need to actually congratulate. She actually wrote an SMS to me, like to pass her congratulation remarks on her behalf. Huh? Oh, congratulations again. Huh? In fact,
Thank
you are
you.
actually one of like our best students I noticed so far. Like we do have very few, but who are very, very active, like very concentrated. I encourage you like actually to continue like this. Huh? I encourage
Thank
you
you.
to continue like that concentration. That is very important. So if we encounter those kind of people, you are actually going to see like a lot of many changes in the future, like especially in the professional practice. Huh? Okay, thank you and congratulations again.
Thank you, sir.
Okay, fine. So adrenal gland is very important gland, by the way. So the objective for this session, so at the end of this session, you are expected to know the regulation and the physiological role of the hormone produced by the adrenal gland, then recognize the clinical presentation of Cushing syndrome and the physiological consequences of excessive cortisol. So remember, cortisol are very important, but of course, when it is too high, it actually have devastating complication to the body system. Then describe how we are managing this condition, especially Cushing syndrome. So we do have several types of adrenal gland disorder, but for today, we are going to concentrate more about the Cushing syndrome. Then let me start the physiology and anatomy of the gland. So remember, the gland is located on the top of the kidney. They are very tiny and small, but they are very, very important for our life. So it contains outer layer and innermost layer. The outer cortex is actually the predominant portion of the gland. It like accounts like 90% of the gland. The other 10% accounts like the innermost gland, which is known as adrenal medulla, which contain 10%. But remember, the medulla section is very important for production of catecholamines, which are very important hormone to regulate blood pressure, even to get energy during fight-flight response and etc. And of course, they can be even administered exogenously when a patient is having a cardiogenic shock. So those are the kind of things you need to know about the physiology of the gland. When you look at the innermost layer, the outermost layer, the cortex, it has 3 layers. The top layer is glomerulosa, the middle layer is fasciculata, and the innermost layer is zona reticularis. So each layer is actually producing different types of adrenal hormone. Then the innermost part is actually adrenal medulla. So when you look at like the section of the adrenal gland, you can actually even see how predominant is outermost layer. It accounts like 90%, other 10% is adrenal medulla. Okay, then the zona glomerulosa part of the cortex is mainly involved in the production of mineralocorticoid. So aldosterone production is actually occur from here, from the glomerulosa part. Remember, aldosterone is very important for sodium and water retention. That is very important. Of course, it actually promotes excretion of potassium as well as hydrogen ion. That is the principle of zona glomerulosa. So you can actually even imagine if there is a problem in this part, we're not producing aldosterone. If we're not producing aldosterone, what will happen? We're not able to retain water and even sodium. As a result, we're actually not excreting potassium. So the patient encounter even hypercardemia, hyponatremia, even volume depression, depletion will be happened. Then the middle layer, fasciculata, it accounts like 60% of the cortex. This is actually like most portion of the cortex and mainly producing glucocorticoids. Remember, glucocorticoids are very important adrenal hormone. They are very important in fat, carbohydrate, and protein metabolism. And apart from that, the production usually follows the circadian rhythm. So mostly the high secretion occur early in the morning and usually peaks at 8 a.m. That's why you will see happy faces in the morning is actually because of cortisol production is very high early in the morning. Yeah? So usually it will go away, by the way, yeah, because it is just like when the time reaches or when the level of cortisol going down towards the end of the day, after we actually wake up, then the cortisol level will be reduced, then that puffiness will go away. And apart from that, you can actually even see cortisol is very, very important hormone, especially it is one of the counter-regulatory hormone in the fasting state. We do have catecholamines in general, catecholamines, we do have growth hormone, and we do have cortisol. Those are the counter-regulatory hormone in the fasting state that can prevent us from having hypoglycemic episode during nighttime and during the fasting state. The level will be low so that they can actually endogenously producing sufficient amount of glucose so that the body, especially the brain, is dependent on glucose. So that is why hypoglycemia is very, very fatal as compared to high sugar level, because the brain will only depend on sugar. If there is deficiency of sugar, means the first cell that will die will be the brain tissue. So that is why it is very, very important. Then reticularis is mainly important for production of androgen. Remember, both male and female have androgen. The source of androgen in a female is from the adrenal gland. Role mainly for having hair, like in the pubic areas, in the armpit and the sea. So it is very important. Hair growth is mainly due to the androgen. Okay, good. So that is the principal role of the hormone. Then when you look at the synthesis of adrenal or steroids, the primary precursor is actually the cholesterol. So that is why cholesterol, despite it's very bad, it's very important as well, because it is a primary precursor for steroidal hormone from the adrenal cortex. Cholesterol ultimately after many metabolic pathways, aldosterone will be produced, then cortisol and even adrenal androgen. So currently, we do have like several drugs we can actually inhibit several pathway in synthesis of adrenal hormone when the level is significantly elevated. We do have a drug specifically to inhibit this portion so that cortisol will not be produced in case of Cushing syndrome. Okay, so this is just like to show you. I'm not going in detail about this one, but it's just like to show you cholesterol is the primary precursor for all adrenal hormone. Then regulation is similar, hypothalamus pituitary adrenal axis. So under normal condition, ACTH will be released from the anterior pituitary, then by corticotropic releasing hormone from the hypothalamus, and ultimately it activates the production of adrenal hormone. But this one is mainly for cortisol and androgen regulation. So HP axis is mainly regulated, or cortisol production and androgen renal gland production is mainly depend on by the HPA axis. Okay, then this is how the negative feedback or the regulation look like. Hypothalamus, there is releasing hormone, then there is adrenocorticotropic hormone from the anterior pituitary, then there is adrenal cortex. So when the level is high, then there is a negative feedback mechanism that can block at the level of pituitary and hypothalamus so that there is no excess level in the cortisol, or there is no excess cortisol level in the body system. So this is how it look like. Then the regulation for adrenal androgen is the same as I said before. But what you are supposed to know is the aldosterone regulation is usually complex, and mainly it is involved by renin-angiotensin aldosterone system. But other adrenal gland hormones are mainly regulated by HPA axis, but what regulates the production of aldosterone is mainly the renin-angiotensin aldosterone system. So maybe can someone briefly describe what RAS system is? Maybe who is willing to give us? Okay, Patel, sorry, no, there is no Patel here. Dorothy?
Yes.
Can you briefly describe?
Okay, so the regulation is like done in the kidney. So when there is like low blood pressure or something that, yeah, so when there's a stimulus, renin is activated, and renin activates angiotensinogen from the liver, which will be activated to angiotensin 1 by angiotensin converting enzyme. And after that, that activates aldosterone. So aldosterone is responsible for sodium reabsorption. Yeah, that's what I can recall for now.
Okay, fine. Yeah, good observation. So the next slide will show you about the regulation of renin-angiotensin aldosterone system. Remember, what normally stimulates the RAS system is mostly a decrease in circulatory volume. It is just normally the repetition of what we have seen in the previous semester when we are discussing about blood pressure regulation. So RAS system is one of the most important regulatory mechanism, specifically in the long-term regulation of blood pressure. So when the circulatory volume is reduced, maybe because of dehydration, maybe because of excessive bleeding or fluid loss, what will happen? Now, there is shunting away of blood to the peripheral organs, such as to the kidney. So because of that, the kidney senses when there is hypovolemia. So it releases renin. So this renin will act to convert angiotensinogen from the liver to angiotensin 1. Then there is AC inhibitor, which is produced, AC enzyme, which is produced by the lung. Then it converts angiotensin 1 to angiotensin 2. Then angiotensin 2 by itself is vasoconstrictor, so that it can actually increase total peripheral resistance and increase blood pressure. And apart from that, angiotensin 2 can actually activate the hypothalamus, especially the posterior, to actually activate. There is osmosis center, by the way, in the hypothalamus, so that we can drink water when there is reduced blood volume. Then also, hypothalamus can actually increase the release of antidiuretic hormone, so that to retain water from the collecting duct of the renal tubule. So that is the action of angiotensin 2. Then angiotensin 2 in the adrenal gland, it can increase the release of aldosterone production from the zona glomerulosa part. Then aldosterone will causes the collecting tubule to retain sodium and water, so that we can restore the circulatory volume. So this is the endogenous regulatory mechanism. So RAS system is the one that regulates aldosterone production. But remember, even when the potassium level is very high, even aldosterone synthesis can also be activated to excrete sufficient amount of potassium from the serum. So that is how RAS system look like. Then the next slide is to show you the physiological effect of glucocorticoids. By the way, like before we are going to see the physical effect of glucocorticoids, we are not going to discuss about the disorder. So what is the role of glucocorticoids? So glucocorticoids, the word gluco stands for because of their ability to produce glucose. So this class of drugs in general, they can increase the production of glucose and also inhibit glucose uptake and metabolism. Mainly, or the net effect is increase the level of glucose. That is the principal role. Then they do have catabolic effect. Generally in the muscle, the effect is usually catabolic. They also decrease protein synthesis. So muscle wasting is very, very, very common. So when a patient is taking glucocorticoids exogenously for a long period of time, you will encounter a muscle wasting. Then when you look at the effect on fat, they can cause degradation of lipid, but on the fat metabolism, they do have like two effects: increased degradation as well as synthesis. But mostly, the net effect is actually causing accumulation of fat in some part of the body, especially around the abdomen area and around like the back areas of the cervical region. We'll discuss later. On the liver, they do have synthetic effect. Mostly, they increase the production of sugar. That is the role. Then, what is the effect of glucocorticoids on the immune system? But mostly, they suppress because immune system, this class of drugs, they can actually cause significant depletion of lymphocytes. They are lymphotoxic, by the way. That is why sometimes they are also useful in the management of even some kind of hematological malignancies. I think that one we'll discuss because of the effect on the lymphocyte count. And because even they inhibit the inflammatory reaction, they can also cause even suppression of the immune system. So what about the effect of glucocorticoids on acid production? Do they have any effect on acid production? For example, if a patient is taking prednisolone because of maybe, what do you say, maybe rheumatoid arthritis, or maybe because of any other autoimmune condition, the patient was on long-term prednisolone. So do they have an effect to cause peptic ulcer disease? Who is willing to try? Vivian, can you try?
I'm sorry, I don't have any information on this.
So what have you discussed about peptic ulcer disease, causes of peptic ulcer disease? That is GIT pharmacology as well as GIT disorder. That is why I was just intentionally asking you. Any other person? What are the most common causes of peptic ulcer disease? Brian, hey, this one you have to know. Even some of you might have even taken the regimen for peptic ulcer disease. Brian, can you try?
I don't know.
What causes peptic ulcer disease? Oh, you have forgotten. Huh?
H. pylori.
Yeah, H. pylori, yes. H. pylori and other?
Also NSAIDs.
Then steroidal anti-inflammatory drugs. Those two are the most common cause of peptic ulcer disease. But of course, even long-term use of glucocorticoids can actually cause what? Peptic ulcer disease. But do you know how glucocorticoid causes peptic ulcer disease? Remember, there is membrane phospholipid. membrane phospholipids, there is phospholipase C. Then this phospholipase, membrane phospholipid will be converted by phospholipase C to arachidonic acid. So this arachidonic acid is a precursor for production of different prostaglandins and even production of bicarbonate. So when you give glucocorticoids, it can actually inhibit the phospholipase C so that it prevents the production of arachidonic acid, which is a precursor for bicarbonate production, which is a protective prostaglandin. So especially like the prostaglandin that is produced by the COX-1 pathway, they are protective because they increase mucus production, they increase bicarbonate generation. So when you give glucocorticoids, they block this one so that protective prostaglandin will not be produced. So production of bicarbonate will be reduced and mucus production will be reduced so that the patient can have erosion in the. So HCl can actually even efficiently causes erosion of the gastric lumen. So that is why when a patient is actually taking a steroid for long term, make sure you have to add proton pump inhibitor. That is very, very, very important. Otherwise, they will come up with another complication known as public ulcer disease. I don't know whether you got what I want to say. So they can cause suppression of the immune system. They can actually even causes increased destruction of the GIT lumen by suppressing the production of bicarbonate and mucus. And of course, because of their activity to inhibit the inflammatory prostaglandin COX-2, they do have anti-inflammatory activity. So that is some of the physiological function of glucocorticoids. Then what is the effect of glucocorticoids on the cardiovascular system? Remember, glucocorticoids, apart from producing increase the sugar level, they do have some mineralocorticoid activity. Like the hydrocortisone, like the least potent glucocorticoids, it has high mineralocorticoid effect. Because of its mineralocorticoid effect, they can cause sodium and water retention and ultimately increases cardiac output. Of course, the mineralocorticoid effect of glucocorticoid usually varies. You can actually, I hope Anthony will take you through when he was when he's actually discussing about the corticosteroids. So, like the beta-methaxone, the dexamethasone, those newer, the most potent glucocorticoids, the mineralocorticoid effect is very, very minimal. In case, if a patient is having a fluid-like disorder such as heart failure and hypertension, we are supposed to use like the least mineralocorticoid, or glucocorticoids that does not have significant mineralocorticoid activity such as beta-methaxone and dexamethasone. I think you can actually read what are the most, like almost nil, like the beta-methaxone, beclamethasone, almost the mineralocorticoid effect is almost minimal. But for hydrocortisone, it is very significant. So like in case if you do have heart failure and you are supposed to use intravenous use of hydrocortisone, it is not usually advisable because it can cause retention of water and exacerbate the condition. Okay, so in renal system, because of a mineralocorticoid effect, it can actually regulate in water and electrolyte balance, as you know, the effect of aldosterone. So this is a bit of the background of the adrenal gland and its physiological effect. Then now, let me take you briefly, in the next few minutes, let me take you briefly about the adrenal gland disorders. So generally classification will be due to, or classification is, or they are categorized as hyperfunction or function of the gland, then hyperfunction usually involves excess production of the renal hormone, mostly cortisol. When the cortisol is high, we call it Cushing syndrome. When the aldosterone level is very high, we call it hyperaldosteronism. So this is hyperfunction. But hypofunction can affect any or all adrenal hormone depending on the etiology of the disorder. Adrenal insufficiency, we're going to say it's Addison's disease. So in general, what are the major disorders of the adrenal cortex? Cushing syndrome, hyperaldosteronism, and even adrenal insufficiency. We call it Addison's disease, and we'll discuss later, like when all levels of the cortex are low, we call it adrenal insufficiency. So those are the major disorders in the cortex, but the major disorders we can encounter in the practice in the medulla section is pheochromocytoma. If you remember, I mentioned when we are discussing about the etiologies of secondary hypertension, the most common cause of secondary hypertension is pheochromocytoma, which is a tumor in the adrenal gland that promotes the production of catecholamine. Okay. Good. So those are the major conditions we are going to discuss. We are going to start from Cushing and followed by aldosteronism. Then we are going to discuss about adrenal insufficiency, and lastly, we are going to talk about adrenal medulla or pheochromocytoma. Then we will end the issue of adrenal gland disorders. Okay, the first topic we are going to discuss when the result of hyperfunctioning of the adrenal gland is the Cushing syndrome. So I don't know whether you came across a diagnosis of Cushing syndrome. So this is how the patient look like. You'll see abnormal fat distribution, like especially in this area, we call it buffalo humps. I hope you know about how the buffalo humps look like. You will see stretch markers because of the effect on the skin. You'll see like they're not pregnancy lines. The pregnancy line is usually at the middle, like from the belly. Then you'll see the skin become bruised easily because of the, it can actually causes like thinning of the skin, and they can easily like they can be easily bleed. The thin and arm are very thin. This is actually because of muscle wasting, catabolic effect of the cortisol. So, and sometimes even you will see like the puffy faces, the face actually become happy. Okay, so this is how the patient look like. Is there anyone who come across a patient with a diagnosis of Cushing disease or Cushing syndrome? But it is not very common, but in KNH, you might get a case of this condition. Okay, fine. So let's see, Cushing syndrome. So this is a clinical condition mainly due to chronic exposure to excessive levels of glucocorticoid. So any factor that increases the level of glucocorticoids, cortisol, in the chronic level, we call it Cushing syndrome. So what causes mainly? It could be due to either supraphysiologic cortisol production, that is due to endogenous hypercortisolism, or due to exogenous pharmacological replacement. So those are the two most common causes of Cushing syndrome. But remember, the most common cause is usually excess secretion of ACTH from the antipituitary. We call it Cushing disease. So when you say Cushing disease, it is actually excess production of ACTH and ultimately increase the level of cortisol. We call it Cushing. So the problem is from the pituitary in case of Cushing disease. But when you say Cushing syndrome, it can be due to either Cushing disease or it could be even due to pharmacological therapy. So any parameter with increased level of glucose due to pharmacology or endogenous, we call it the Cushing syndrome. But the disease is when it is caused by any adenoma, and the pituitary that produces ACTH ultimately increases cortisol level. We call it Cushing disease. So you have to know the difference between the two. So lastly, when you look at the epidemiology of this condition, it is very common in women. I don't know why. I tried to search a reason, but I couldn't get like very perfect answer. Very common in women than in men, and ACTH-dependent Cushing syndrome is very, very prevalent. It accounts like almost 80% of all Cushing syndrome causes. So ACTH-dependent is very, 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 very common. So because of this, the pathophysiology we are going to discuss into two: ACTH-dependent and ACTH-independent Cushing syndrome. So ACTH-dependent means when it is actually due to adenoma when there's adenoma, that increases production of ACTH, secreting adenoma. But ACTH independent is usually, it is independent of ACTH stimulation, or it could be due to exogenous glucocorticoid administration. So there might be a condition that can actually cause ectopic production of ACTH. We're going to discuss on Wednesday, and there could be due to exogenous glucocorticoid administration. So we call it like ACTH independent causes of Cushing syndrome. So I think for today, because of time, let me stop here so that you can prepare for the next class. So if you do have any question, you are welcome. Any question? Okay, so if you can read like Cushing syndrome or adrenal gland disorder before the next class, so that when you come on Wednesday, we can have like a short 10-minute breakout session like